Let me have the great honor and pleasure to welcome you again to the formal start of the 6th Global Patients Congress. We will have Members' Day today, and tomorrow and Monday morning we have multi-stakeholders days. I thanks for the advisory committee members. Some of the members are on the floor. They help us to develop a very exciting program for the 2.5 days. This year, the theme of our Congress is Better Access, Better Health, a patient-centered approach to universal health coverage. In our communications and contacts with most patient organizations around the world, the most concerned issue is access to health care. Universal health coverage is raised by WHO. The aim is that people can take the healthcare service they need without financial hardship. But this is just an aim. How to define universal coverage, in particular, how patients' perspective on universal coverage is most important for the years to come. So in the coming few days, I hope everybody can learn and can know more about universal health coverage, and also contribute to IAPO to that IAPO to develop our own statement on patient-centered health universal coverage to advocate at the international platform. So I hand over the time to Joe to start today's program. Thank you.
Thank you, KP. Great. So the aim of this session is to outline the issues around universal health coverage, because that's the theme of the Congress. And so this is so we have a common basic understanding of the issues. And today we have really the best opportunity we're going to have with so many of you. I think there's over 100 people, which are member representatives here just today on our own, to explore what issues we have around access to health, to share our understanding of what universal health coverage is, and sort of the opportunities and challenges it presents to us, to look in breakout sessions on what it means on a regional level and other common issues or other very different issues, and to work really hard in discussion together on what the principles are that we as patients want to be promoting and advocating for, as the WHO, as KP said, works to support countries around universal health coverage. So by after the Congress, we'll be bringing all of that together and be able to develop a policy statement which we can all use in our advocacy efforts. Just a bit of housekeeping. Please, I mentioned it earlier, but please either turn off or turn to silent your mobile phones so that we can all engage in the discussion. And now, to tell us more about universal health coverage, I'd like to hand over to my colleague, Rachel Seal-Jones, IAPO's Senior Policy Officer. Thank you, Rachel.
Thanks, Jo. So, as you already know, this year's Congress will explore the theme of better access, better health, with a particular focus on universal health coverage. So, why did we choose this theme? Well, firstly, in consultation with all of you lot, our members, we have realised that access is the #1 issue facing your organisations. And we know that this definition may vary from region to region, but the fact that it came up so often was really quite pertinent to us. The second reason is that universal health coverage is increasingly being recognised as a priority area for the World Health Organization and its member states. However, we feel that there is still a bit of a lack of understanding on what UHC means and a lack of the patient voice in discussions on universal health coverage. So that's something that we think that this Congress can address over the next few days. So what is universal health coverage? So Margaret Chan, Director General of WHO, has said that it is the single most powerful concept that public health has to offer, and that universal health coverage ensures that all people can use health services without financial hardship. So WHO does not want to dictate how countries move towards universal health coverage, and we understand that there are many different paths and many different countries will choose different financing mechanisms and means to get to this approach. However, within this, there needs to be the patient voice, and that is something that has been missing. So broadly speaking, universal health coverage aims to, has the following objectives. Firstly, there needs to be equity in access to health services. The services need to ensure that they are high quality, and they need to ensure financial risk protection. And this requires a strong, efficient, well-run health system, a system for financing health services, access to essential medicines and technologies, and a sufficient capacity of well-trained, motivated healthcare workers. So from the patient perspective, those first two objectives are areas where there is a real opportunity for us to define what is meant by quality and equity and point out gaps in provision. So on this slide, you can see a slightly complicated diagram, but this really goes to show what is needed to achieve universal health coverage. So you can see that, first of all, you need to ensure that the number of people covered by health services increases, therefore increasing the equity of services. You need to ensure that you are increasing the amount of cost sharing across populations and reducing out-of-pocket payments, which is the top bit of the box. And thirdly, you need to ensure that increasing amount of services are covered. So in many health systems moving towards universal health coverage, they may start by just having a few services covered, a few essential, if you like, before moving towards a more comprehensive system. So you may also remember a few months ago, we undertook a consultation with you to find out what access to healthcare means to you guys and what your understanding of universal health coverage is. So you can see from this slide a few of the key words that came up, and unsurprisingly, health and access are right at the forefront of that, as well as treatment, services, quality, medicines, etc. And most of you highlighted the importance of accessibility to healthcare infrastructure when you were talking about access to healthcare. So in the forms of hospitals, healthcare centres and treatment facilities. But this also was not just the facilities themselves, but the distance that people had to travel to get to these services and eligibility of services. You also highlighted the importance of timely access to diagnostics and treatments and the importance of equity of access. When we asked what your understanding of UHC were, the general consensus was that the accessibility, quality and affordability of healthcare services were key aspects of universal health coverage, which is in line with what we've already said in WHO's definition. But you also highlighted the need for highly trained health workers. Where we did see differences was in the variety of responses on how UHC could be financed. So some respondents highlighted that all healthcare should be available for free for a prepaid taxation system, whilst others felt that there should be a minimal level of services available without cost, with patients making additional payments to top up their healthcare. However, despite these differences, there was a consensus that on the whole, the cost of healthcare should not impoverish populations. So, to support your understanding of universal health coverage, we have developed 2 information papers, which you can find copies in your delegate bags, so please do have a look at those. The first paper is the information paper on UHC, which provides an overall introduction to UHC and some of the things that we've talked about at equity and quality. The second paper is country examples towards universal health coverage. So this highlights examples from Mexico, Rwanda, Japan, Ghana, Thailand, and Chile, and who have all developed innovative strategies to expand healthcare coverage across the population, and also on how they've done that and how they finance that. So some of the questions we want for you to consider whilst reading the papers and also today, for the rest of the day, are who defines what is meant by quality and equity in healthcare? What role should patients have in the design and implementation of universal health coverage strategies? And how can patients support the monitoring and evaluation of universal health coverage strategies? This has been so far missing from a lot of the discussions on UHC, but it's something that we think is essential. So I'm going to hand back to Joe to talk a little bit more about what we're going to be doing today. Thank you.
Thank you, Rachel, for that brief overview. And as she said, there is plenty of reading material that we've compiled for you as background information. We're going to move swiftly on because we want to get the discussion started and think about, for patient representatives, what the issues are. So we've got a very esteemed panel of member representatives, and to introduce them, I'd like to invite, again, Durhane Wong-Rieger to the stage, IAPO's immediate past chair. Sure.
We're just going to do it from here. Thank you. I mean, this is really, first of all, thank you very much for the backgrounder as well, Rachel, in terms of an introduction to universal health care and coverage. Really, I think this is a great opportunity for us to set a bit of a stage for what's going to happen this afternoon. And I think this is an opportunity to hear some examples from different countries or different disease areas in terms of what has been happening in terms of getting better access to universal health care coverage, and also maybe some of the challenges that the patient representatives have experienced, some of the successes, and maybe the lessons learned from those successes to take again into the discussion, and maybe a little bit of some of a reality check. Because I think we all say universal health care coverage, but I would imagine that even for us in the most developed countries, where we feel like we have pretty good health care, I'm not sure I include you guys, Mark, but it's okay. As we know, we do know that Canada has a wonderful healthcare system, but we actually recognize that in Canada as well, we have some real challenges in terms of what we would call sufficient healthcare coverage, and I would say, same in terms of many of the developed countries right across Europe as well. So I think we all recognize that there are many things that are in progress. So we're going to use our panel to actually help us talk about some of those issues. Really, the purpose of this is really to explore, I think, some of the issues around universal health care coverage, to really get some opportunities to hear, as we said, some examples of what is happening, what are some of the challenges, what are some of the lessons learned from it. And really, I really want to invite the panelists, because I think, as Joe said, these are really some of your leaders that have really made the advances in terms of universal health care coverage, their personal insights in terms of what's working, what's not working. We're amongst friends here, so I think you can be as frank as possible, even though you are being recorded, so just to put you on the record a little bit. No, seriously, I think we are among friends, but we're also really wanting to learn from the realities of it, so I don't think we need to do polite political statements here. We really do want to have the opportunity to get the advantage of your insights. And then as you know, we will have an opportunity this afternoon to go into some of our regional meetings and really hopefully be able to expand upon these discussions there. So without really much further ado, what I'm going to do is we have a bit of a format here, but I think we'll be a little bit flexible about it in terms of how we approach it. What I'm going to do is ask each one of the panelists to briefly introduce himself or herself, kind of the disease group area or the region that they come from, and to make maybe just an opening statement about what their sense of, you know, how universal health care or universal health care coverage, and I have a difficulty with those two words, because universal health care is one thing, universal health care coverage, I think, is a slightly different thing. And so sometimes I think we try to use them interchangeably, and they don't quite interchange quite that well. But I'd really like them to introduce a little bit about, you know, maybe using as part of your opening statement, you know, with regard to the patient population that you advocate for. What do you think, you know, has been the advances in terms of healthcare coverage for your patient organization or the region that you're in? And in what ways have you seen, you know, universal health care and healthcare coverage really improve access or equity or the quality of care? Okay, so we'll do as a brief introduction, and then we'll kind of pose some other questions for you to discuss. I think it'd be nice to do it as a panel discussion. Is that okay? Okay, I'll start with Eva Maria. Just introduce yourself, etc.
Okay. Good morning, everybody. My name is Eva Maria Ruiz de Castilla. I'm coming from Peru, and I represent the patients who have NCDs and cancer. I work especially in the rare cancers area in Peru, and I was working a lot to have a cancer plan as a part of the universal health coverage system who are building in my country progressively. So I wanted to start this discussion because it's an important and interesting topic for all of you as a patient groups working to have better access for better health, finally, you know. In 2012, the UN declaration about the universal health coverage make an appeal to do something urgently about health, to cover the people who are dying without any care. So the WHO make a resolution and give some steps to the countries to move forward the universal health coverage systems. In Latin America, the situation is very interesting because it's improving progressively. I have to be very positive about that because we cannot stay saying that, oh, there's nothing, we're not doing anything about, we're dying, we're still dying, or, you know, we have to be positive and enthusiastic about this topic. If not, we never improve the universal health coverage. And because it's a very complicated topic and a very complicated policy, we cannot improve the systems immediately. It has to be progressive, you know? And I wanted to share some examples in the region as the best, I think the best one was Chile. The second maybe will be Mexico. My colleagues from Mexico are saying that there is not improved right now, but I think we are trying to. You know, in Peru it's the same. We vote and we approve the policy for universal health coverage in 2009, and we start the policy and try to cover progressively the poor people and the poor population. So we are a country who has 35 million of inhabitants, and we cover just 12 million. So you can imagine how many people are not covered right now. So, but the 12 million has now the full right for access to health and to access for medicines, and the best medicines that we can get for them, especially in cancer. But, you know, you always see that the diabetes are not covered right now, so we have to improve the patient voices, and we have to be positive, like if we talk with the government and with the ministers of health, we can build a special program. There is a lot of positions about the progressively models, but I think it's the only way. As an ex-public functionary, I promise you, there is no funds. It's very difficult to improve the systems, and it's very difficult to pay, the access for medicines or care for everybody. So we have to advocate. We have to improve the policies, and we have especially to have the plans, and the plans will be by 2 years, 3 or 4, but we have to build something to have a policy for advocate and then improve the system. I think we can share another example like Colombia, who was the full care, and the universal health coverage system. But the situation in Colombia is that the system was very good structured, but there is a I don't know what can I say that in English. It's the judicialización de la salud. So it's the jurisdiction of health. Sorry, it's a very difficult word. But now, because of the law, the people who wants to have any care, they just write to the ombudsman a letter and they take the care. But it is complicated now because there is no money to pay to everybody, so the system is not improved. And let me finish. So we have to think about the regulations, the model of taxation too, and the legislation to do universal health coverage. I think it's, and improve the human resource to do that, access to essential medicines, so regulation for that, and health systems.
Thank you very, very much. That was a good smattering and some real honesty there. Orajit, do you want to talk a little bit from the perspective of Thailand? Introduce yourself and your organization.
Okay. Good morning, everyone. I'm from Thailand, Heart to Heart Foundation, and maybe everyone now know Thailand better from the political situation now. But it's okay. Don't worry, because Thailand is a peace country and Buddha country, so nothing will happen that serious. Like also the universal health coverage in Thailand, it starts from the people movement as well. Since by the health security system is started in 2002, we have the National Health Security Act in 2002. But before that, we have people movement, because like Maria Rose said, that people, they have difficulty in get access to healthcare, health service, and also they have to pay out of pocket. So it's very hardship for those poor people. And then we have like this consumer protection society, and also the AIDS society and NGO. They gather together and they have about almost 50,000 signatures, and they propose their health security system to the parliament. And after that, the government, they accept and they proceed with the National Health Security Act. And it's also, when it starts, it's good luck that we have those people or patient representative to develop the system as well. And in our board, in the health security board, we have 5 representatives from the NGO and the patient, and also 5 from the local government. The rest is the government sector and the experts. And in the board, the people or the patient voice is very strong. They can they have a voice in order to ask for the benefit package that respond to the patient needs. And now I can say that most of the benefit package or the medicine or the health service is come from the patient voice in the board. And then we also have patient network to support the board also. And so what I would like to say that is collaboration between the healthcare sector and with the NGO or the patient and also the academic people. They are very important. And this is something that if you have a forum, including with all those stakeholders, maybe like IAPO have doing at the moment, I think it's a very, very good approach in order to develop the healthcare system in order to fit with the needs of the patient. But there are also some obstacle or some problem right now because in the remote area, the people, especially the poor people, they also have difficulty to get access to the health service, maybe because of lack of understanding or lack of ability to come to the healthcare unit. So right now we promote, in Thailand, we promote a lot in the home care or the community care with the collaboration with the community and the local government. And we think that this is something that IAPO can explore and develop later because the community care or the home care with the collaboration with the volunteer or the patient in the community and the support from the local government is also something that to make it possible for the patient to get access to the health care. And now we also, 5 years already, Thailand, we have initiated, like we can say that is promotion, health promotion fund, co-chair, the government, they have some fund to the local government and it's co-contribute some portion by the local government and we make it like a community fund, mainly for the prevention and promotion and rehabilitation service with collaboration from the community and the health volunteer and the patient. So this is, it can outreach to the people, especially in the remote area. So in Thailand, we have something to challenge and explore more and more. And also maybe you know that the health security system in Thailand mainly or mostly from the government budget. So it's some criticized from the political or from the policy level that, oh, it's a big burden to the government. So now we try to have some more contribution from the local government to increase the contribution from the local government and also have some community fund to integrate it. And that is our situation.
Thank you very much. And you can see that working at a variety of different levels, with Eva Maria talking about how do you actually work with the policymakers and how do you influence, as she says, the policy and the legislation to actually get universal health coverage defined, get it legislated, and then to be able to expand the services. But it's an interesting concept she's saying is that out of 35 million people, maybe 12 million people have what would be considered to be quality, services. And then what we're hearing from Thailand is somewhat of a different experience, and that is very grassroots, very much, people pushing for getting access. And access, and I think as she's brilliantly said, and I think what we also learned when we were in the Philippines, it can be defined in different ways. So on the one hand, we are talking about, health services, professional health services, and trying to expand that. But we're also talking, as you say, in some of the rural areas about how do you develop then a much more of a grounds-up grassroots network that may not be just the professional care delivers, but how do we actually provide then for people to be able to do health promotion prevention or even primary care at that grassroots level that is really funded quite differently. So a different notion of what that might be, reaching different people, but, as you say, continue to expand. So patient organizations, patients themselves having certainly very strong roles, but in somewhat different ways. So great. And now I think we'll hear even different experience from Matthias in terms of talking about universal healthcare coverage. I think using some of your experience in terms of AIDS, but maybe speaking more broadly in terms of Europe and Germany as well.
My name is Matthias Wienold. I come from Germany, a country where I'm proud to say we've had universal health coverage for the last 130 years. So you'd actually wonder why I'm sitting up here. I'm part of a European group which was founded 22 years ago, which decided that we wanted to expand coverage into areas where it wasn't reaching. Even in a system like Germany, we weren't able to reach drug users, we weren't able to reach homosexual men, we weren't able to reach discriminated populations, and in these discriminated populations, discrimination is the major killer. It keeps people from accessing care, it keeps people from accessing health, it keeps people from taking care of themselves. So within universal health coverage, there's a big issue around discrimination of social minorities, and I just point you to the international discussion about the discrimination of homosexuals that is going more and more in several countries. We voted for Uganda today. I don't know about the sexual identity of the candidate that we voted for, but if he is homosexual, he will have real difficulties working, finding care, because even his caretaker will be, or his care provider, will be taken to court for providing care to a homosexual. So these are the issues, even if you read universal health care, that are inside the package. If you, and that is the lesson that we've learned, if you don't look at the most vulnerable populations, and you were mentioning the rural populations, you were mentioning those who are poor, if we don't really look at the most vulnerable populations, and if we don't really take care to develop them and their perspective, we're going to lose the entire battle. We're going to provide care for a majority of the population, and we're not going to be able to overcome the burden, or to at least adequately address the burden of disease that stems from discrimination. What I would like to point to as examples of how we dealt with this and how we are rolling out the idea of be respectful of our needs in developing universal healthcare is the European Community Advisory Board. Since the European Union didn't have and doesn't have a mandate to rule on health issues in individual countries, on health care issues, on universal health coverage in the European countries, we had to set up our own board. We had to build our own structure where we could bring together the people that we thought were on our side as minority representatives or as people from AIDS service organizations, and invite the politicians, invite the decision makers, invite the pharmaceutical industry, invite the regulators to really get everything set up so that the minorities get their right to health worked out within the framework of universal health coverage. One of the issues that came to me 2 years ago was this is a transgenerational task. It's nothing that happens while I'm going to be alive. It's nothing that happens while I'm going to be able to teach it, but my task is to teach it to the next generation. So in 2 weeks' time, I'm going to teach a group of 20 people from 20 European countries, young people, on how to become activists, how to engage in patient-physician communication around arranging your own healthcare under expanding healthcare systems. The two examples, and I mean you can just follow the link that was provided with the invitation for this session to read up more about the European Community Advisory Board, which has mostly, I must say mostly, the European Union as its geographic region. In expanding that, we also needed to account for the fact that English, which is our common language, and that's also an issue when you become transnational. English, which is our common language, is not spoken all across Europe. So, as a consequence, and you today see the results also of the political developments behind it, we helped to set up a Ukrainian community advisory board, and we helped to set up a Russian community advisory board that covers the Russian region. Now, today we are seeing big issues there. Universal health coverage in Ukraine, meaning that people who are drug users, people who are HIV positive, will receive their care with international support. Ukrainian government unable in its current function to really step in a decisive fashion, but hopefully will be. People trying to stay under that umbrella, now being forced to live in a country where neither opiate substitution treatment is available, nor homosexuality is legal, nor antiretroviral therapy is provided for people who want to have it. It's provided to people where the physician decides they need it. So it's a really difficult situation where, under the heading of we provide universal health coverage, I must say I'm privileged in a situation to really see that this is broken, the promises are broken by the overwhelming interest of politicians to discriminate. And I think we really need to make a strong statement to stop discriminating people, because otherwise we will fail with our programs.
Excellent. So we've gotten some very, I think, again, powerful examples that are somewhat different in recognizing, as you say, even under very good universal health coverage systems, there are lots of people, and especially, as you say, marginalized people, marginalized for lots of reasons, who do not have coverage. And I think many of us can also recognize that within that also not only are people poor or people with mental conditions, certainly I know in Canada, a huge discriminated population are those that are at risk in terms of hepatitis C, because many of them happen to be drug users or in prisons, and in some respects, again, we don't do that kind of necessary outreach. So, and a very interesting example, as you said, in terms of developing the community advisory groups, where, in fact, the people themselves, again, have taken on the role of trying to advance that agenda. So I think we've got some great examples there in terms of. We're going to open it up to the floor, actually, for some. I mean, I know that each one of these panelists could probably speak a great deal more, and I really applaud them for the restraint in not speaking a great deal more, because I think we do want to have an opportunity to actually engage you either in raising an example or providing a question. Before we do that, I just want to raise two examples that I remember we got from the Latin American, when we did the first Latin American Congress. And I remember Marula. Those of you who know Marula Siegel as a powerful patient advocate in Latin America. And she heads up an organization mostly for lymphoma and leukemia patients in Canada. And in Brazil, there is coverage. And Brazil, you have a right to have access to treatment if it's available. The problem is that in most cases, you have to sue the government for it. And so this is Marula's organization. And if any of you ever visit her organization, it's a gorgeous office which is filled half with social workers and half with lawyers. And so the social workers get the cases, and then the lawyers sue. And Marula got to the point where she says the government was spending so much time having to respond to her lawsuits that they finally called her up and said, Marula, the next time you've got a lawsuit, could you just call us ahead of time, we'll just settle it. I mean, but that's an interesting, sad statement in terms of universal health coverage, right? But I'll give you another example again from Brazil. Again, the right to access to treatment. So in theory, universal health coverage, and it's interesting that Eva Maria says diabetes is not considered to be covered necessarily in Peru. But again, in Brazil, you have the right to insulin. A young mother, daughter with type 1 diabetes, no insulin, because you have to have a diabetes educator in order for the patient to get access to insulin. There were no diabetes educators. So what she did was raise funds and hired herself a diabetes educator. And they actually then got a diabetes educator, got access to insulin. She then set up a foundation in which she actually then hired and got funding to do 2 diabetes educators. And they went out and actually did and got more insulin. A group really got one of the business schools, recognized what she was doing, helped her set up a large website where she actually could do solicitations into companies to get donations. She now hired 60 diabetes educators. And they began to do the education, and everybody got access to insulin. Well, lo and behold, the government said, in retrospect, they looked at it, this is actually working. We're actually saving people. It's actually cheaper for us to be able to educate people and give them insulin. And they took over the role of funding the diabetes educator and providing insulin. She began to spread into the more rural areas in terms of Brazil, in terms of continuing to do that. But again, you know, lots of solutions on how you take what is actually there, but patients and patient organizations have to, in many cases, take that initiative in order to make it work. So we'll stop there, open it up for people. If you would like to raise a question or provide an example, I'm going to urge you to not follow our example in terms of speaking too much, but provide it very briefly so we can give as many people as possible an opportunity to either provide sort of a thought or an example in terms of universal healthcare, or actually take advantage of our panelists if you've got a question or a challenge that you would like to also put forth.
Just a question for Eva. You mentioned...
Could you introduce yourself and what group you're from?
Yes, Rosemary Nadjim from the Arrhythmia Alliance. You mentioned that the central government needs some more help from local government, you know, with funding. And I just wondered, is that through a system of local taxation? You know, where do the local government get their funding from?
Who are you addressing it to?
To Eva.
To Eva.
Yeah.
In Peru, we consider the 4% of the GDP as a budget for health. So I say that taxation will be important to improve the universal health coverage if we have a formal taxation system, you know. Like in the countries like mine, we are trying to improve the formal taxation system to improve the formal resource to pay health, you know, and other sectors like education, you know, sanitation and other different necessities for people. So it will be important to have a very good, you know, system in place to improve the system. And I say, when you talk about universal health coverage, there is no model, you know, as a model itself who work in every country. So it will be, in my side, a model for my country or for my region maybe. But the model that we have in Peru doesn't work for Colombia, which is just in front of my country. And there is the same kind of population, but there is no the same policies and the same budgets for improve the universal health coverage. So I don't know if I answer your question.
Orajit, would you like to add to that? Because I know that you talked a lot about what the local governments are contributing back up.
Yes. It's happened that in Thailand, we started 10 years ago about the decentralization policy to the local government. And in that mandate, also including the health service. So the government has to provide or contribute their fund from central government to the local government. And the local government, since they also have some revenue tax from their area, they also can have their own fund to contribute. So this is the same approach for the universal health coverage in Thailand, that for the health promotion fund that we initiate, that is some approach about the decentralization about health service to the local government and to the community. So this is the same approach, but we have this kind of mechanism that we call health promotion fund in order to drive it, to make it possible. And from the universal health coverage in Thailand. And since every Thai people, they have to get access to healthcare or need to health service from the government, is some kind of welfare. So it's in the constitution as well. So we need some kind of a strong mechanism for the community and the local government to drive it. And it's happened that the local government, they are willing as well, because this is their mandate, and they have more fund from the central government. And what is some obstacle or problem is the knowledge or the education for the local government as well. Maybe you people know much more than me that the local government, they still need some knowledge or education about the disease, some disease or some healthcare that they need to provide to the patient or to the people. So we have a close collaboration between the healthcare sector and the local government in order to collaborate and to develop efficient or a quality healthcare service to the people. This is ongoing.
Yes, I would like to add the aspect of actually relieving local authorities of some responsibility to and shift it over to a health insurance system. In Germany, until 15 years ago, even though we had a universal health coverage system, it worked in a way that for the poor who couldn't afford insurance, the local government would pay. Now, this meant a really big burden on the big cities, because the poor were moving to the big cities, because that's where they found markets, that's where they found social support, that's where they actually found places to live as well. And the big cities, rather than the regions around them, the richer belts around the bigger settlements, were really burdened with that expense and weren't receiving any compensation for it from the regions around. What I see today, 15 years later, now that every person in Germany is insured, and there's not even for somebody who comes back to Germany after 10 years, if he's there, he will have his health coverage through the health insurance, is that we're seeing a decrease of competence, medical competence, political competence on the local government level, and that now it is up to the patient organizations actually to train the local politicians rather than reality framing their experience.
Okay, so interesting. Sounds like there's going to be some interesting dialogue within the regional tables as well. Another question. Yes.
I'm Robina from Uganda. I want to thank all of you for these presentations. I wanted to speak to other factors other than the finance that really constrain access, universal access. And I think in our communities, you see that even when you have a midwife and a very clean and equipped health center, many of our women and young people are making a choice not to go there. So I think empowerment in the background, in the overview, really, and that is this constituency's responsibility. I think empowerment needs to come out very well, and you have spoken about it across the board, but also empowerment. You talked about advocacy. I think the chair talked about advocacy. Advocacy for us to push governments to the realization, to the continuous realization according to what governments are able to give. We have in Uganda been able to push with Parliament and demonstrate and get government to add more and more to the budget. So the advocacy, I think, also should come out in the overview, in the background. But also the legal, you mentioned the legal, and I think it is coming out from the Germany presentation. The legal policy framework is also a big, big, big constraint to access. And you said Uganda, and I come from Uganda. So that needs also to be addressed in the overview.
Thank you very, very much. Maybe we'll go to Luis, just to kind of continue to kind of have the dialogue from the audience.
Lars Ettarp from the International Federation of Psoriasis Associations. I have not heard any one of you say so much specifically about access to doctors, because you must have a diagnosis before you can have a proper treatment. And IFPA, which is the abbreviation for the International Psoriasis Association, has been working in Africa for quite a number of years. And even if we don't have a skin disease nowadays, it's recognized as an internal disease. It's a disease which really can be seen. And discrimination and isolation of people and so forth have a quite specific situation in Africa. You can be thrown out of your tribe, your family, lose your job because you are looking differently. And it's not a question of the best medicine all the time, because some medicines, traditional medicines, are working well, even if they are very greasy. But it's more a question of how to get the diagnosis and how to find people who can give basic help in especially Africa. And you know, we have psoriasis have been for 1,000 years also been mixed up with leprosy and syphilis, and nowadays HIV. But in a country like an African country like Tanzania and Kenya, they have, I think, about 20 fully trained dermatologists and rheumatologists, each of about 40 together. And Kenya have, for example, 33 million people, inhabitants in the country. How to deal with that? You must, if you shall have success, engage other doctors than the real specialists, and you must have a system for self-treatment and all these things. And I think it's idealistic to talk about the right access to medicine as long as you don't have a correct diagnosis. And don't forget the brain drain in these countries, because the fully trained dermatologists have a much more better future in London than they have at home.
So can I add some comments about your comment, because it was not a question, it was a comment. And I wanted to talk about the essential package that they define the universal health coverage system. You know, it's the essential benefit that the population could have in the system that where there's no access for help. And this essential package include good infrastructure, good human resource, not only doctors, because we need a multi-sectoral concept of this, you know, and then the very reaction on time to have a good diagnosis, a good intervention, and a good results to guarantee the quality of life of any patient. So we don't miss, or we are not specifically talking about the doctors, but we have to think about the human resource as a policy. You know, it's because when we start, say access to the essential medicines, human resource, and well-run health systems to have the three conditions to achieve and to improve the universal health coverage.
And I think you raised, as you say, some really important factors that outside of just having either legal or financial otherwise at the end of the day, you've got to be able to deal with the social stigma, you got to be able to deal with the prejudice that the healthcare system itself may have in order to make sure that everybody goes back to what I think Matthias is talking about in terms of marginalized populations, is that how do we make sure that everybody does get included when we're talking about universal health coverage, and including, as you say, some issues around stigma. I think there was a comment. Luis, did you want to make a comment?
Eva María me va a ayudar para que quede bien dicho las cosas.
En español.
I'm acting as an interpreter.
Ya. Creo que hoy en día todo el mundo está diciendo que la salud tiene que estar centrada en el paciente. Desafortunadamente, no estamos incidiendo en la toma de decisiones donde hoy en día se está hablando de la cobertura universal.
So he's telling that we are not talking about the universal health coverage as a patient-centered healthcare system. You know, we are not talking about the patient as a center of the healthcare.
En todos los países hoy en día existen foros donde hablan exactamente lo mismo, pero no hay pacientes de todas las enfermedades discutiendo estos temas.
So in every country that he's having meetings, they are talking about this topic, but there's no patients talking about exactly the disease or the problems.
Y creo que hoy en día tenemos que empezar a trabajar con redes de otras enfermedades para imitar lo que pasó en VIH.
And we have to work with the networks in other diseases like HIV to share the example and the good practice who happened with HIV in the past.
Porque si no estaríamos nosotros mismos discriminando a nuestros propios pares.
If not, we are discriminating our peers if we don't work together.
No podemos dejar de ver la salud si hoy en día no estamos realmente haciendo redes de trabajo, pero lo más importante, empezar a definir qué es acceso universal y cobertura universal.
We have to work together and we have to define very well what is universal health coverage and what is access for health.
Thank you very, very much. And again, I think what we recognize is that, you know, not only do we need to have patients, as you say, speaking up as advocates, but we need to be able to network across patient groups and be able to speak together and to speak for each other. Okay, we're going to run out of time very quickly here. Okay, so KP, can you make a very quick comment here?
Sure. I want to give a question to both Matthias and Orajit. As to my understanding, in Germany and in Thailand, you both have a relatively better universal health coverage system. But I want to know whether your patient organizations are satisfied with the current situation and what areas they are going to advocate for much better quality or more service areas?
Okay, so very briefly, even in the German healthcare system, patient organizations are asking for improvements of access to health, for speedier drug development, and also for improved specialized services like the example of psoriasis. The number of specialists available for certain diseases is very small.
In Thailand, I can say that the patient organization, they more or less they satisfy with the patient engagement with the government, but they still need to work more in the benefit package for the patient. Like now we have the kidney disease already included in the benefit package, right? Because that is mostly they are all high cost disease. But it's also have some problem like some medicine or some service that also sometimes the hospital they neglect or they not provide that service to the patient. Then we have so we say that is the complaint system. We have call center 1330 24 hours for the people or the patient. They can complain, and the criteria is we have to respond within 72 hours respond and to solve that problem. If not, the problem have sent to our board as well. So the patient, they have so many channels in order to develop the system more and more. And also sometimes we have, you must ask that how about the healthcare provider? There's unsatisfaction with this time, with this situation also, because they have been forced more and more in order to provide better service. So we need some kind of understanding and collaboration among those stakeholders. That is more important.
That actually is a very powerful kind of a bringing it back full circle, and that is, we can talk about patient-centered healthcare, and we can talk about the importance and the role of the patient advocate, but we also have to talk about the patient as a partner in the system, recognizing that the healthcare professional and the other stakeholders in that system have also got to be fully engaged, and that our role as an advocate is not necessarily to put people on the other side of it, but how do we actually become part of the system, become part of the solution. And I think you've heard some really powerful examples as well, is in terms of patient advocates and patient advocacy groups, not just challenging the system, not just trying to overturn the system, not trying to take over the system in that way, but working to expand the services. I think the other thing that was raised very powerfully there is the importance around not just having more services and not just including more people, but what about the quality? And again, it speaks back to, I think, what we heard previously, and that is, if the providers are not fully engaged, if they're also not satisfied with what's being proposed for them, they may, in fact, be unwillingly drawn into the system in a way that does not assure both equity in terms of quality care. So, I mean, I very much appreciate what Wim said before in terms of, I think, our role as patients. Our role as patients certainly are to be raising the standards in terms of what we believe is, in fact, good patient-centered healthcare and what is essential in terms of healthcare coverage, making sure that we as patients, when we're speaking, are speaking on behalf of all patients. So we aren't talking about just one patient group or one disease or one region or one area. I think the other thing that we are talking about, though, is how do we become responsible partners in that? And how do we also push for patient engagement in a responsible way, responsible use of healthcare resources, giving back into the system to make sure that what it is that we're asking for is also very responsibly, I think, used in every respect. I think everybody also recognizes that, I think as Eva Maria says, you've got to have funding in there. So part of the real initial challenge is how do we assure that we've got funding that is going to be sufficient to cover the healthcare needs, and whether that is high central level, whether it's local level. And you've heard some of the pros and cons of making it too much one level or the other, so that's kind of interesting, is where, you know, we take away your responsibility to actually fund it. We also then take away your knowledge and your commitment in terms of providing that service. So it's an interesting kind of a challenge that we have there. I think the other thing that we do recognize, and I know that Regina has talked a lot about it from the point of view of African countries, is that if you're not enforcing the taxation system so that those who do have and are being taxed are actually contributing, you'll never get to universal health care coverage. I mean, it's one thing to say we want to include all of those who are financially, you know, unable to provide for themselves, but the only way we're going to do that is if we can actually make sure that we've got the resources coming in, and that includes all of us in terms of the you know, developed countries as well. Unless we've got, you know, a fair taxation system that people will contribute to, it's not going to happen. I know there's lots of other questions, and I'm really mindful of the fact that we're totally out of time, but I am going to turn it over to Megan, who's going to talk to you about, I think, the regional settings coming up, where you have lots of opportunities to not only share your thoughts in your regional meetings, but also we'll have an opportunity to bring it back and also add then and continue the discussion. So it certainly sounds like IAPO has struck on an important theme. This is certainly a topic that covers right across you know, around the globe in terms of an important issue, has many different kinds of shades to it, and certainly many different types of solutions. I was going to try to give each of the panelists a final word, but I think we're going to run seriously out of time if we do that. So we're going to encourage everybody to have the opportunity to really participate vigorously in your regional meetings and bring these discussions back to our plenary. So I'm going to turn it back over to Megan.
Thank you.
Thank you very much. On behalf of the entire audience, thank you to our panel. It really was a wonderful and interesting discussion that brought out some really key points. And thanks, Durhane, as well, because this really does set us up for the afternoon, where we were going to be in a lot more detail about the regional meetings. My fellow staff members are going to be handing out just a brief description on how the regional workshops are going to be run. And after lunch, we're all going to meet in different rooms. And in your directions that are going to be handed out now and in the program, there's a description on where each room will be. And it'll be across the hall, outside of this room here, across the passageway in the breakout sessions. And board members and staff members will be helping facilitate, but I'd like each member in each group to elect a chair who will be feeding back in the afternoon session. So we could break out in those rooms in each region, come back to this room, and each chair will present back on the key issues at a regional level, and we'll start drafting a set of principles from a patient's perspective. But again, thank you so much to our panel. Thank you so much to the good questions and issues that were raised from the floor. Lunch will be upstairs, and it starts now, and if we could please be in the regional breakout rooms from 2 o'clock, that would be most appreciated. Thank you.